So welcome to our fifth session. Today our topic will be medical ethics taken by SUNITHA doctor. So we can start with doctor's presentation followed by its discussion. We can start our case presentation by 4 o'clock and followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in.
Good afternoon. So today we are having a very important session. We do many activities in interventions, including medications and some maybe procedures. All are based on ethics. Ethics is an important part of medical practice, which we are going to hear more from Dr. Sunitha. Dr. Sunitha has done her MRCP in palliative medicine from UK, and presently she is working in General Hospital as a part-time. And she has good experience in palliative medicine in India as well as abroad. So Sunitha, welcome, and it's over to you.
Thank you, Sunil. Am I audible to all?
Yes, ma'am, you are.
Okay. Good afternoon, everyone. So today's session will be about medical ethics. Next slide. So what I'm trying to do in the next 45 minutes to 50 minutes is basically go through the cardinal principles of medical ethics using a case scenario as a background. And once that is done, there'll be a few other case scenarios, which is probably for you to have a think about and have discussions. Because this is not like because it's not possible to do as a workshop here, because it's like the echo session. We probably won't be able to have a group discussion, or but in between, if you have questions, you can ask, or we can leave it till the end. But there'll be a few case scenarios to discuss. I'll also briefly mention about the principle of double effect. What are the core ethical obligations we have to do as a palliative care physician? What are the challenges that we face in our day-to-day activities, day-to-day work, to get these ethical principles put forward to the patient. I briefly mention about the end-of-life care, where I think most of our ethical dilemma or ethical issues probably deals with when we deal with patients who are dying. So the ethical issues involved in the end-of-life care. And I'll conclude with mentioning some of the recent developments in the field. Next slide. So whatever talk that I'm giving here is just basically covering with reference to palliative care. So I wouldn't be going into the research ethics or other ethics with other physicians deal with. This will be what we deal with as palliative care physicians. Next slide. So if all of us are familiar with this definition from WHO. Maybe we started studying this in the second or third year of medical college, where health is defined as the complete physical, mental, social well-being, and not merely the absence of disease and infirmity. Now, to be quite honest, I understood the meaning of this definition only after I started working in palliative care. Because till then I was working as a physician, and we were just looking at the disease. We were just giving a diagnosis. We are going to treat the disease, make them well, send them home. So we don't deal with the total care. So I think the WHO probably gave this definition with them having this. It's an old definition, but probably had the specialty of palliative medicine in their mind for the future. Next slide. I hope this picture is clear. When you think about, or when we think about the discussion for today, I want all of you to picture this patient. So it's basically an elderly lady, one of the patients that Pallium India has looked after, who is lying in a bed which doesn't have a cot. You can see that. She's emaciated. She's frail. She actually looks very scared and anxious. You can see the brick walls there, which is the old-fashioned brick house. The bricks are not properly kept, windows open. So she's a very, very poor lady who's emaciated, who's scared, who's and maybe in pain also. And she's lying at her house. Now, what I'm trying to do is, for the next 40 minutes, our discussions, is it going to be useful to her? That's what we need to find out. And I suppose when we do our daily job also, that should be in our mind. A picture of a patient like that should be in our mind. And whatever we do, is that going to be beneficial for her? Next slide. Why ethics? Next slide. So I'm not sure whether everybody is familiar with this. There's a verse in the Bible, in the Holy Bible, in the Gospel according to St. Matthew, chapter 7, verse 12, which says, "Do unto others as you would have others do unto you." And I think this should be the basic principle, I suppose, for all the treatment or whenever we deal with a patient, or obviously the basic principles behind ethic should be that. So when we try and make an ethical decision regarding any situation, regarding any patient or any scenario, typical one is probably giving all those life-sustaining treatment for a patient who is bedridden but quite awake, and reaching end of life stage, who's got an incurable disease, but giving the mechanical ventilation and all those treatment. And I've had an experience where I've had a session with a few doctors, local doctors in the state, where we were discussing bioethics, and that scenario is coming up in the slide. So basically, it's a question of giving platelets and transfusion every time an end-stage liver failure patient comes to hospital with a GI bleed. Will you do it or will you not do it? And the question was, and the doctors felt they should do it. But when we are, because they was like, if it's my father, I would want to do it. But when we asked them the question, what if the patient was you? What if it was you? Would you want us to do that for you? And then the answer was quite clear. No, I don't want anybody to do that for me. So we sometimes selfish in that way. We would want things to be done. I'm not saying we don't love our parents, we do. But the thing is, we want to keep them alive because we want to see them. That's the reason we want them to be alive, not because they're having a quality of life. And once the situation has changed, it's reversed, and we are in that situation, we don't want to live like that. So the basic principle of ethics is do unto others as you would have others do unto you. Next slide. What are the 4 cardinal principles as applied in of ethics as applied in palliative care practice? So I'm sure everybody must have heard about all these principles. What I'm going to do is to go through each of them one by one. The first one is patient autonomy, which basically means that what does the patient want? And does the family understand the patient's preferences? So it's not what you want for the patient, what you want as a treating doctor for the patient, but it's what the patient wants and understands. And again, the patient is the main person here, not the family, which again, culturally, we don't quite follow that. We always go with what the family wants, but that's our culture. But actually, what we should be thinking is what the patient wants, and does the family understand their preferences? That's patient autonomy. Beneficence. So we are doing lots of treatment for the patient. Is it beneficial to the patient, or is it a benefit that is perceivable to the patient? So we might think what we are doing is actually benefiting the patient as a doctor, but does the patient feel that it's benefiting to him? Does he get any quality of life with that? Does he want those things to be done for him so his life can be prolonged? Is that what he wants? Third one is non-maleficence. So basically, it means that do no harm for the patient. So when I do something, is it going to create more harm for the patient than any good? Our intention is basically to do good for the patient. That's what we have all, taken our oath, and we have started the job. But when we're doing something, are we unintentionally causing any harm for the patient? Is it doing more harm than good? And the last cardinal principle is justice. Is it a fair utilization of resources? The classic example that we always say is when people come to a government medical college where there's only 4 ventilators, which is always full. Do you put a young person with organ of phosphorus poisoning has got getting going to respiratory arrest or end stage heart failure and end stage COPD patient who actually won't benefit from a ventilator? Will you put, and an elderly gentleman, will you put that in that patient in a ventilator? Which is a difficult decision because we are not gods. We can't decide which patient get what. We can't decide that. But when the services, so that's why I took the example of government medical college with only 4 ventilators, which was like that when I did house surgery. Probably it's still the same, I'm not sure. But we have to make the decision because all the patients need it and we don't have a choice. The scenario is different in private hospital where you can just get how many ventilators you want. So that's when the principle of justice comes. Is it a fair utilization of resources? Is it beneficial for the how is it affecting the family, for the community? Next slide. Yeah, next slide. Next, yeah. So basically, we've got all those on one side. The theory, I've told you all the theory on one side, and we know that. But then in theory and practice are the same, but in practice they are not. So we know the theory, we know what to do, but when you come to practical situation, it's not that straightforward. And each case has got individual merits. So each case, we have to go through each scenario, have in-depth discussions, and try our best to put that theory into practice. Next slide. So our Constitution of India guarantees a life with dignity throughout. So when it continues to say that actually the recent amendment says that we have to also have die with dignity also. So we should have a right to live with dignity as well as die with dignity. So when this patient, if this patient becomes unwell or get a chest infection, and she's taken to a hospital, if they're affordable enough to go to a private hospital, then obviously if she's got an infection and she's got respiratory failure, she's going to end up in a ventilator. Will her dignity be respected if she dares to go to hospital? That's the question. That's the question that we as clinicians working in hospital should be able to answer. And honestly, when we see patients, are we able to give them the dignity in the hospital as the right is? Is that possible in hospital? Next slide. So the first principle, patient autonomy. How is the patient involved in decision making? We'll start with the clinical scenario. Next slide. Yeah, go on. Next slide. Next slide. Okay, so we've got a 20-year-old boy. He has got osteosarcoma of the lower end of femur. He has a large tumor, size of a pumpkin. There are multiple lung metastases, and he's got severe anemia. He wants an amputation right now. You explain the risk to him, and he says, "Doctor, you decide for me. What will you do and why?" So have this case in your mind. So it's a young chap. Again, very difficult, not straightforward. As far as I am concerned, with palliative medicine, young teenagers, kids are difficult to manage. He's got osteosarcoma, large tumor, and it's spread. So it's not curative. It's the palliative stage now. It's metastatic now. So his lung mets are there. He's got severe anemia, and he wants an amputation due to various reasons. It can be either because of the large size and it's quite painful. But he can't decide because there are risks and benefits involved. Next slide. Patient autonomy. So how do the patient get an informed consent? So our job as a doctor is to explain to the patient what will happen if you do an amputation or if you don't do an amputation, and what are the pros and cons involved. And then the patient has to decide by himself. That is basic principle of autonomy and informed consent. Obviously, the family gets involved in decision making, but eventually it has to be the patient's decision. That should be the final one in the ideal situation. Now, there are some patients who would, in some cases, some patients which they would refuse treatment. Like again, a typical example is, Jehovah's Witness refusing blood transfusion due to their specific reasons. Religious reasons are there, and they can refuse treatment, and that's entirely up to them. We can't force them to take any treatment if they don't want to take that. So our job is to, when there's an informed refusal, our job is to check the understanding of the patient. Does the patient understand what happens if they don't take the treatment? We have to try and find out the reasons why they are refusing to take the treatment. So explore the reasons why they are refusing to take the treatment. And I think there are some situations when we feel upset. We feel that's not the right thing to do. We feel the patient might die if it's not being done. But we still have to agree with it because it's a patient's decision. That is patient autonomy. We can't make them do things because we think that's what they've decided is wrong and they should do the right thing. It might harm their life, but still that's what the patient wants. So we'll have to go with that. Next slide. when we respect patients' autonomy, then we respect them to take the decision. And basically, the patient should be able to, with us, with our help, should be able to identify the goals of care. So any treatment, when we plan for a patient, it should be for the best interest of the patient, and it should be to improve the quality of life. So different patients at different stages of the diseases have got different goals of care. So if it was, if the osteosarcoma patient was presented at the early stage, initial stage, and with no meds whatsoever, then it's straightforward. You can do an amputation, you can do the, depending on that, surgery is indicated, and probably that's a curative. So at that point, the treatment might be curative. But then once he has crossed the metastatic stage, the goals of care is different. Our idea is not to prolong things. We can't, our aim is not to prolong things, because we can't prolong much. He is going to die pretty quickly. So our aim or the goals of care should be to keep him comfortable and give him quality of life as long as he is alive. So is it the cure of the disease process, or is it the maintenance of the best possible state of health? In a chronic disease condition, when we can't cure it, are we trying to maintain a best possible state of health? And is it to maximize comfort? And based on the patient's values, they'll have some values and thoughts about the whole thing. So based on the patient's values, we have to try to reach an agreement about the goals of care. Now, usually it involves a compromise, and it might not be what we want the patient to have, but it's what the patient wants. So we have to try and reach an agreement about the goals of care. Next slide. Then there is a situation where patient can defer decision making and identification of goals of care to family member. That actually upholds autonomy, and we can have lots of examples of, even elderly parents, when they say, let our children decide. I'm happy for them to decide. I don't want to say anything about that, which is very common here, because they've reached a stage when the decision making power is automatically gone to the young children. They have sort of taken a side role, and they're not involved in any of the decision process. So probably in the medical situation also, they are happy with that. But that's the patient's decision, and we should respect that. And that deferral actually upholds autonomy. But personally, what we should try and do is we should at least make sure the patient knows about what's happening. Now, when a patient lacks the decision-making capacity, the decisions can be made by a surrogate decision maker. Now, recently, again, I'll come to that in the recent developments, the advanced directive. I'm sure that you've heard about advanced directive or living will, where patient is able to write down things that they want to happen in the future when they lose the consciousness. So basically, you can discuss things like feeding issues. If you lose a solo, do you want to be having NG feeding or not? If you're if you have respiratory failure, do you want to be put on a ventilator? Now, classic example is motor neuron disease patients, where we know that it's a progressive neurological condition, and we know that what is going to happen next is what is going to happen in the future is one is solo is going to get affected, and the second one is respiratory failure, and they can go into ventilator. This is a classical thing. Everybody knows that unless they get probably a chest infection that is going to kill them, they are all going to go in that same route. So then we have this advanced directives or living will, when we say that, okay, if that happens, I want a peg feeding or not feeding. You can write you want it or not. You can. The importance is if you don't want it, you clearly state that. Then we are supposed to respect that. So because once they reach that stage, they probably are not able to communicate. So either the speech goes or they become unconscious, and somebody has to make a decision for them. So that is the surrogate decision maker. And they can and they can, in the document, they can assign people to be the decision maker. So it can be a spouse, it can be the partner, it can be an adult child, parent, sibling, sometimes even friend or distant relative can be a decision maker. And if the patient hasn't written anything down, so normally if the patient has decided, then usually what we would feel is the decision maker would know what the patient would want in that situation. So if that patient hasn't got anything written down, then the decision maker should decide as the patient would decide, or something should be done in the best interest of the patient. So they can't make a decision as to their own decision. It has to be what they feel the patient would decide, or in the best interest. Next slide. Okay, so that's about patient autonomy. We move on to beneficent, that is, do good to the patient. Next slide. So in this patient, what are his biological prospects? In this patient or any other patient, when we decide on any treatment, whatever we do, is it going to cure the patient? Is it going to prolong his life? Next slide. Next. Will it improve his, previous slide, okay. Will it improve his quality of life, and will it take care of any distressing symptoms that he has? So most of the, and I think probably we are the only specialty who would think of the last two lines of that. So everybody thinks about the fact that whatever treatment we give, is that going to cure the patient, and is it going to prolong the life? Only these two things are normal. Even culturally, probably everybody, we are only interested in, are we going to live long, and is the disease going to be cured? That's the only thing that we are worried about. But when we are living longer, what is our quality of life? Even if I am living longer, am I going to have a better quality of life? That is something that we need to ask. And will it be a symptom-free quality of life? Will it take care of any distressing symptoms? So the question is, do I want to live without a quality of life? Do I want to be just alive and have all those symptoms, but be just alive? Or do you probably won't have a shortened life, but with better quality of life? That is the question. So whatever we do for the patient, is it going to benefit the patient? Next slide. So will the proposed intervention have any perceptible benefit? It should be an appreciable benefit. It's called perceptible benefit. Is basically it should be perceptible to the patient. It's not a benefit that we feel, because we can think of a number of reasons. We have studied that if you go, when a patient comes with this specific diagnosis, you give this treatment, it'll work. But is that treatment going to benefit the patient? The patient should appreciate the benefit. That's the whole question. Next slide. It's difficult to define a benefit, because it's a subjective situation. Physicians' definition of benefit may be different from that of the patient's definition. Next. And the best option would be, for us, previous slide, would be to go with the patient's definition of benefit. So always when we are in a dilemma as to the discussion is, it's beneficial to the patient, but who thinks it's beneficial? We think it's beneficial to the patient, or does the patient think it's beneficial to him? And I think when we put that in the scales, we should go with the scale which says that it's beneficial for the patient, always, not with what we think, because after all, it's their life. So we should always think about it that way. Next slide. I've got two slides with the the graph showing the disease trajectory. One is acute disease and one is a chronic disease. So acute disease is where when a patient gets a diagnosis of illness, when they're healthy and they suddenly gets an acute illness, where the condition drops down pretty quickly. So it's a sharp drop down, and then they are sort of in the have got probably very critically ill in the ICU on those days when they are near death. That graph line, when it says near death, and then they improve, they get better. They've got a lot of reserve, they get better, and they gradually go back up and go back to the normal baseline healthy level. So such patients don't have a life-limiting disease or diagnosis. No cancer. It's just they probably had an infection, chest infection, very bad pneumonia, but they're not a smoker, so the lungs are fine. So whatever acute injury they spent some time in the ICU, that's fine. But their body's reserve was well enough for them to go back to the baseline level. So the graph shot up and they're back to the healthy self. Next slide. But that's not the case with the the incurable disease, a chronic disease diagnosed patient. What happens is they're healthy and the diagnosis happens, and they get a lot of treatment. They get appropriate treatment in the early stage, and then previous slide, they get appropriate treatment in the early stage, but still the condition is going to deteriorate because it's an incurable and it's a progressive disease. So invariably, whatever we do, we will buy some time for the patient, but the condition is going to deteriorate, and they're going to reach a stage when obviously they're going to die, and that is a downward dip. So that's the difference between a chronic life-limiting condition diagnosis and an acute illness. Next slide. So how do you define futile care? The goal of the medical care is to achieve a benefit which is above a minimum certain threshold level. So in these conditions, when the baseline, the acute illness, we want to bring them back to the normal self. That is the baseline we are trying to achieve. For chronic illness, every time they get an acute infection, they do come back, but they don't come back to the original basic line because the graph is coming down. So you can have dips in that graph. You can have dips down the graph. They bounce back up, but they don't come back to the original height. They come to a lower slope. Then again, they come back up, lower slope. So always a threshold comes down. And that's when it reaches the end, whatever care you are giving becomes futile care. Because futile care is a care that fails to achieve the benefit. So we are targeting for these patients some benefit above minimum threshold. We want to achieve that for the patient. Once we know that we're not going to achieve it by doing the same thing, then whatever care we are going to provide for the patient is futile care. So what it says, the medical futile end of life care, the document says that we as physicians are not ethically obliged to deliver a care that, in the best professional judgment, will not have a reasonable chance of benefiting the patients. So as I told you about advanced directive, in advanced directive, you can refuse to have ventilation. You can say, I don't want ventilation. But if you write, I won't have ventilation, the physician is not obliged to provide it. Because if you feel, the physician feels that it's not in the best interest of the patient, it's not in the best professional judgment, you can't be forced to do that. It clearly stays in the end of life documents, and legally they can't make you do that. And again, later I'll be giving you some position statements from the Critical Care Society, which clearly gives guidelines as to how to go about withholding ventilation and giving ventilation. So basically, we as physicians are not obliged to give any treatment which and even it's a peer group thing. So you can discuss with other doctors of same training, and you can consult with one or two doctors, and everybody agrees that is going to be not for beneficial patient, then we're not obliged to give it. So the patients can't demand a treatment which we feel it's not in the best interest. Next slide. So whatever care we provide should be based on objective facts, not a subjective thought that this might work. It should not be a subjective belief and prejudices. There's lots of anecdotal treatment that happens, which I would say happens in palliative care also, but ideally it should be based on objective facts and should be evidence-based, and it should be based on expertise and experience. But this is difficult. It's not always clear-cut, and there always been an element of uncertainty. So then, like when a patient with this cancer diagnosis comes with chest infection, you give antibiotics, they actually bounce back and get better. Next time they come with an infection, and you remember the previous scenario when we gave the treatment and they got better. You're tempted to give more treatment because we're not sure. It's difficult to say when is the last event, which is sometimes they might recover and they might come back to previous, not the baseline, but how they were before the infection. The thing is, one of those days, one of the infection would be the terminal event, and it's probably it needs lots of expertise and experience, and also communication with the patient family to decide when do we say we're going to stop it, and we're not going to give any more antibiotics for the next infection. Because sometimes when we go through in the previous episodes or in the previous 1 year, what would have happened is the patient would have come and maybe been in hospital for 2 months, got better, went back, and after 2 weeks they got another infection. They came back again. So whatever baseline they got back to is only lasting for 2 weeks. It's not lasting long enough for them to have a perceptible benefit for them. So that's when we come to a point when we decide that actually, is it a futile care? Am I giving the right treatment? Is it needed or not? So there's always been an element of uncertainty. We might not be always sure that this is the right thing or not. Next. Okay. The third principle is non-maleficence or do no harm. I don't think I've pronounced it correctly. You can get it from, I think you can get pronunciation online now. So the correct pronunciation, you can get it. So basically it says do no harm for the patient. So whatever am I doing, am I harming the patient? Next slide. Is the intervention going to harm the patient? And for us, it's our four cardinal principles of managing the patient should always come to us. So is it physically going to harm the patient? Is it going to harm the patient emotionally? Is it going to harm the patient financially, which is very, very important? And again, one of the only specialties we probably thinks about the financial aspects of the care, and the social one. Is it going to harm the patient socially? Next slide. So is it painful? Will it cause any more physical disability? Does it cause any more emotional trauma? Obviously, amputation in that child. I don't know how, even though he asked for that, I don't know how he's going to go through a life after with an amputated leg, young chap. So is it going to cause an emotional trauma for the patient? And is it worth it? Can we actually control the pain with medications rather than going straight for amputation? Is that possible? So is the treatment going to have any physical side effects? Will it lead to further social isolation? In his case, it might lead to further social isolation because he wouldn't want to see any of his friends when he doesn't have the knee, the leg below his knee. So he wouldn't want that. Financial drain, obviously, if he's going to a private hospital, then it's a financial drain for the patient, all the surgery. And is it in line with the patient goal, the goals of care? Is that what we want for the patient? So is it going to harm the patient in that way? Next slide. So weighing the, it's always a balance, isn't it? So you have to weigh the benefit versus risk burden ratio for the intervention. For each and every intervention, we need to have this balance. Weigh the potential benefit versus potential risk and burdens associated with the intervention. And these burdens, it's not just the physical burdens. It has to be the social, emotional, and financial burdens also. Next slide. And the fourth principle is justice. So how do we know that what we are doing is justified, or is it for the it's equal utilization of resources? It's balancing the needs of the individual with that of the society. Next slide. So in this scenario, is it a fair utilization of the family's resources? So most of the patients who's gone through this cancer journey, once they reach the palliative care, specialty, they would have been drained of all their resources, and financially also drained. And fortunately, most of the palliative care centers are free of cost, which is really good. And most centers like that should come up. So we do target, and I know Palliative is doing excellent work in actually doing palliative care as well as for poor patients. They are providing for chemotherapy and things like that. So they're doing an excellent work, which is really commendable, because we only get patients like that, isn't it? So in a scenario like that, doing an additional surgery, is it going to be, if it's not beneficial for the patient, then should we be using the family's resources to actually do a surgery for the patient? Is it a fair allocation of hospital resources? Is probably what the example that I mentioned earlier on, when you've got 2 or 3 patients who need this hospital bed. And again, even forget the ventilator thing. Even private hospitals, from my experience, actually the ICU bed is usually full. It's not as if they've got empty beds or anything. At least where I was working, the ICU bed was full. And there were situations when, if you've got an end-of-life care patient who is in an ICU bed, who shouldn't be there, but is there only because family wants him to die in an ICU. And you've got a young chap, a septic patient, who's hypertensive and he needs an ICU bed. It's just unfair to the septic patient. Even in a private hospital, that can happen, because I've seen people bargaining for beds and they're shifting patients out and making bed for the patient. So that even can happen in private hospitals. So it's not a fair allocation of hospital resources when we say that our family or somebody who is actually clearly dying should be in an ICU. And it's not a fair utilization of society's and nation's resources. So that's what we need to think of when we think of the justice. Next slide. So to summarize, when we say, when we do a decision of appropriate treatment, which is inclusive of the patient and family, how do we come to that? How do we come to that end of the funnel, where we give it the therapeutic aim and benefits of each treatment should be thought in mind? We need to think about the risk and benefit of each treatment. We need to first think about the patient's biological prospects. So first is the diagnosis, and what is the need for the current treatment, what is the scenario, and what is the goals of care. Are we doing for curative purpose? Are we doing for palliative purpose? Are we doing to prolong life with no quality of life, or are we doing just to for quality of life? And then the adverse effect of each treatment. You have to weigh the risk and benefit. Is it harming to the patient? And then finally, you make a decision, and you have to decide you have to discuss the thoughts with the family and come to a decision, including the family and the patient. Next slide. Okay. Now, there are a few, probably we might have time. Like if you want to chip in between and say answers to that scenarios, 1 or 2 lines, anybody who's interested can just unmute and answer. A few scenarios are coming up. First one is, a 50-year-old lady with carcinoma of the stomach has come into hospital in a terminal state, probably due to internal bleeding. Her systolic BP 60 millimeter mercury. She is very restless, probably due to pain. Will you give her parenteral morphine? Anybody want to say? Yes. Okay. Somebody has typed in S. Somebody has typed in no. Can I? It's another question. Can I listen to the person who typed in no to say the reason?
Dr. Anandakrishnan.
The BP there will be again fall in the BP. So giving parenteral morphine will not be advisable. Okay,
good. That's fine. Next slide. So is it right to give some medication to a terminally ill patient which may inadvertently hasten the person's death? That's a question. And it's a very valid point that Dr. Anandakrishnan raised. Is it right or not? Go back to previous slide. Previous slide. Yeah. So the scenario is a 50-year-old lady. She's got carcinoma of stomach. She's terminal state. We know that she's dying, and she's dying due to internal bleeding. Okay. Which the surgeons are not going to touch her to stop the bleeding. So, and a BP 60 millimeters. So she's already hypotensive, she's tachycardic, and she's going to bleed to death. We know that. Unless a surgeon touch her and stop her bleeding, she's going to bleed to death. What we can do medically is you can give her fluids. You can give her blood transfusion. So you have to give her lots of fluids to bring her BP up. You can take her to the ICU. And you can maybe start ionotropes. When it's not working, you can give her blood. You can keep on giving her blood, but unless the surgeon, and probably you can start some tranexamic acid, see whether it works or not, medical management. But she's invariably going to bleed to death. That's one side, okay? On the other side, she's in a lot of pain and she's restless. So if you've got a patient who is going to bleed to death and die, and in pain and die, or one thing we can do is give her some morphine, make her comfortable, and she's going to die due to bleeding. So this is the ethical dilemma that we are facing. Next slide. So is it right to give some medication to a terminally ill patient? Terminally ill patient is the thing that I'll underline there, which may inadvertently hasten the person's death. Next slide. So we come to the principle of double effect. So basically what principle of double effect means that you are doing something to treat physical conditions. So measures were taken to relieve the physical or mental suffering, cause the death of the patient. It's morally and legally acceptable, provided the doctor's intention to relieve suffering and not kill the patient. So it just means this. In this scenario, what I would have done is I would definitely start fluids for her. She would be having IV access. And you can start with a low dose of morphine and see. We always start with low dose of morphine anyway. You don't give a whack of 10 milligram morphine. You start with 1.5 milligram, do a pain score, repeat it again and see. There is I probably won't repeat her blood pressure because I don't want to know, because she's definitely going to die. I don't want to know her blood pressure. But I can make her more comfortable by giving her morphine. Even if you don't give her morphine, if she's going to bleed, her BP is going to fall again and she's going to die. So the basic principle of double effect is that, and this is one of the things, this is like an acute stage when you are, maybe giving the drug is going to cause a death. That sort of scenario comes in the mind of most of us, even the nurses. But when you think of palliative sedation, that's something that again we use the principle of double effect, whereby palliative sedation is used in any scenario of terminal symptom, terminal pain, terminal agitation, where we are not able to manage with the normal medications and patient is in distress. Then we reach a stage when we have to sedate the patient. The patient is already actively dying because of the illness, but the patient is in distress. So we have a discussion with the family about that, and we decide on starting the medications, and which we gradually increase. Again, we don't start as a very high dose and give to patient. We start at a low dose, we gradually increase the dose till the patient is comfortable. So our idea is actually to make the patient comfortable from her symptoms, but not to shorten the life of the patient. What happens is when they become more sedated, there is a chance that the life is shortened because obviously they become more unconscious, can aspirate and die, which is going to happen either in a 2 or 3 days, later on, because she's going to die anyway. So the idea is our intention of giving a medication is not to shorten the life of the patient, but to make her comfortable and let her have a good death. That's principle of double effect. Next slide. So a single act having two possible foreseen effects. One is a good effect and one is harmful. It's not always morally prohibited. The harmful effect is not intended. So our intention is not to kill the patient. Our intention is to make her comfortable. And that's what I'm saying. I don't give the morphine and check her BP because I don't want to know that. It could be well that she is actually bleeding and dying. Her BP is going to drop anyway. Next slide. Next scenario. So a 20-year-old boy with advanced cancer is under your care. Relatives have insisted that the issues of diagnosis and prognosis should not be discussed with him. When you go to see him one day, he is all alone. He asks you what is wrong with him. What will you tell him? So it's an adult boy, he's 20, so he's adult. Anybody wants to say anything about that?
Anybody want to comment on this?
Okay, no. Okay, next slide. This is not an ACE scenario. I think I probably would want Dr. Sunil's input also into this, because there's a lot of cultural cultural context also into this. If this scenario wouldn't have risen in UK at all, because that is not an ethical dilemma there. Their 20-year-old boy is an adult. You have to ask his permission to tell the father that he has got this specific diagnosis. This scenario wouldn't have come there. So personally, that's the problem. I've done more of palliative care abroad than here. I do find it quite a difficult situation when I deal with patients here, where it's probably, you would have all noticed, like you're having a conversation with the elderly mother, and there's the daughter showing hands and eyes saying that she doesn't know the diagnosis, and you'll be like, not knowing what to do, you'll be playing in riddles and trying not to tell the mother, which is a very common scenario. And I thought I'll sort of read upon that, and when I read upon that, it's not just India, it's an Asian culture. So if there are articles from China and all those Asian countries where it's a cultural norm that you don't tell you don't tell, probably it's the children and the elderly. So you protect the elderly and the children from the diagnosis. So sometimes I've seen elderly patients protect the young son also. So 30-year-old, it's just some people protect some diagnosis for some people. There's no guideline who does that, and it's very common here. Now, is the person or to withhold information the person is asking for at the existence of patient's relatives. And I think because the main problem is the patient is asking you in the face, we shouldn't lie to patient. That should be clear. Our relationship is with the patient, and in order to maintain the relationship forward, we should not be in a position to lie to the patient. So what I would normally tell the family is that actually I wouldn't say anything, but if you ask me straightforward, I will have to say that I can't lie to the patient. Now what that would entail is that the family won't be happy, and they might take the patient away from you, and they'll go to a different doctor. The other way to put that is, I usually ask them is the same question that I ask everyone. If you were in that situation, so normally the scenario is the elderly father who doesn't want to be told, shouldn't be told by my father won't be able to tolerate that, he's so weak-minded, extra. But my father or mother is actually brought you up when you are young, they looked after you and they brought you up, they're not children. And if you are in that situation, would you want to know the diagnosis? And they would say yes. So this is not a straightforward answer, and probably in the end Dr. Sunil will also put his input. Next slide. There isn't much about that. So basically, I think we'll discuss that later on. Next scenario is a 64-year-old gentleman with long-standing cirrhosis of liver was admitted for GI bleed and severe coagulopathy. He develops hypotension, falling SpO2, and worsening renal function. But the family wanted everything else done for him. What do we do in such situation? Should we continue transfusions? What about hemodynamic support and dialysis? Anybody? Okay, this is, I think I mentioned this scenario when I first started. This was presented to, the bioethics session that we had in our hospital to a team of doctors. Same scenario, cirrhosis liver, portal hypertension, GI bleed, coagulopathy. Are we going to do something about that or not? And if you're doing it, how many times are you going to do it? Next slide. These are the life-sustaining treatments. All these major life-sustaining treatments that became standard care of the high-income countries of 60s and 70s. Cardiopulmonary resuscitation, CPR, mechanical ventilation, hemodialysis, blood and blood product transfusions, antibiotics, and artificial nutrition via tube gastrostomy. So one thing that we need to remember is, death is an inevitable truth, isn't it? Whatever life-sustaining treatments we have found for humans that invented, people are invariably going to die when it's their time. These treatments are the ones which is inappropriately given are prolonging things for most of the patients who end up going to ICU. So that's the scenario. Will that patient, so cirrhosis liver, portal hypertension, end stage, what should we do? He should be transplanted, isn't it? That is the treatment. So you have to transplant the patient. Otherwise, it's not going to get better. It's a irreversible stage. He's going to die of liver failure. So what we normally end up doing is we start doing all these transfusions for one admission. They go back home, similar scenario, come back after 2 weeks, same scenario, keep on doing it. How many times in a year are you going to do it? Is it not going to drain the patient's finances? What is the end point? These are things that we need to discuss. And some of the life-sustaining treatments are not appropriate for all the situations. And we need to carefully, including hemodialysis. Sometimes, already having a life-limiting condition, developed acute kidney injury, and to CKD, and then have to have dialysis. If you start it, you're going to come out of that. Is it appropriate for the patient? Are we going to do it or not? So each of this needs to be thought about and discussed with the family. And antibiotics also come there when a scenario when if the patient's infection is going to kill the patient. If you don't give it, we are not giving a life-sustaining treatment. So that's why antibiotics are also there. Similarly, transfusions. Each transfusions are actually, you're giving them, it's like a foreign body thing. If you're not giving it, why do you give blood transfusion for end-stage patients? If there's no symptomatic benefit, there's no point in doing that. So each of these are life-sustaining treatment which need to be thought about and discussed properly before giving to the patient. Next slide. So why do we do it? Why are we forced to do it? Especially working in private hospitals, it's mainly because the patient and families assume that intensive care is the best care and demand it, even for patients with end-stage chronic illness like cancer. Believe that it's their duty to insist that all means to be used to extend life, and believe that physicians recommend not to use life-sustaining treatment only when they want more money or reserve for rich patients. That is a justice thing. Patients probably think it's not because of justice because of the medical need, is a justice of rich and poor. So they think that these are the things that patients go in their mind. It's only for rich people. That's why they're not giving it to poor people. Actually, scenario is other way around. Rich people demand for it. Poor people usually don't demand for it. So it's easy to have an end of life conversations in a private hospital with a middle class family than everybody knows a rich family, because rich family feel that they have to have everything for their father, including intensive care. It's the best care, and that demand it. Some people we had a cubicle in our ward which is called allowing natural death cubicle, so A&D cubicle. We just started basically to clear the beds from ICU. So we do offer patients, so we discuss about withdrawing treatment in ICU and bringing them to the cubicle, and everything is agreed upon. But the idea of bringing to the cubicle is the family can be with the patient when they die. The ideal situation of perfect death where the family members are together. But our scenario says that nobody actually wants to do that anymore, because people haven't seen death. So they prefer that patients are in ICU, they'll be looked after, the nurse will look after, and they're anyway going to die. So what's the whole point in bringing them out? So people are, they think that intensive care is the best care. Even when they die, they get the best care in intensive care, and they don't want the patients to be brought out. Next slide. So each treatment that we give for a patient, the middle one, the circle, is to think about, is it for the best interest for the patient? So if you're giving a curative treatment, is it for the best interest for the patient? If you're prolonging life, again, is it in the best interest of the patient? Preservation function, is it for the best interest? Life support, symptom control, and end-of-life care. Everything that we try and give for the patient should be for the common goal of best interest of the patient. Next slide. What are the core ethical obligations? We discuss the cardinal principles of ethics, but as a palliative care physician, what is our core ethical obligation? Compassion. We all hope that we are compassionate doctors. That's why we came to this profession. We have got compassion. We need to try and give respect to the patients. We need to treat them equal. They are patients. We need to respect them, treat them with the dignity and non-judgmental. So they might make a decision that we think is completely stupid, that we wouldn't do it, but they've got their reasons to do that. So we shouldn't be judgmental. It's their life, it's their choice. We don't have a right to judge them. So we should be compassionate. We should, respect them. We should be non-judgmental, and try and provide, give them a life with dignity and also a death with dignity. Next slide. I just got a message from Dr. Geeta. So do as relatives. Have a relative like that. Wife knows it's not beneficial, but his relatives insist wife does it. Terrible financial situation. Not easy to make patient understand. All the decision must be made earlier. So all these scenarios, day by day, it's not easy to make a decision. So Dr. Geeta is quite correct in that. What are the challenges that we face when we see patients on a day by day? Again, this is a family scenario where individual autonomy is denied by the family. So sometimes the elderly father doesn't want to have chemotherapy. He's had one sort of one cycle of chemotherapy in the initial stage, didn't have much benefit, had some neutropenic sepsis, didn't have any quality of life, but went through that, and after 6 months, the cancers occurred again. The oncologist suggested next chemo. but he doesn't want to go through it, but the family says no, you have to do it. So sometimes some patients are so scared about the family, they'll be like, oh, I'm scared of my son or daughter because he wants me to do it and I don't want to do it. So the individual autonomy will be denied by the family. So what is second is what is valuable, good or right? Okay, next slide. Next is a confused medical system. What is the duty of a doctor? Is it just to prolong life, that is heartbeat, at all cost, or is it to maintain a quality of life? Next slide. And third challenge is what is offered. So it's either artificial life support or nothing. These are some sort of scenarios in the hospitals that can happen. If you do not want our treatment, take him home, but give it in writing that you are taking responsibility for all consequences. That is basically the discharge against medical advice thing that we sign the patients off. So basically is that the patient's family doesn't want ventilation, mainly because of financial reason, but legally we are obliged, or so hospital is obliged to make them sign this form saying that you are taking it home at your own risk. And this happens in all the hospitals, and you can't blame them because they can just turn down and say the hospital discharged you. So that's why it happens. Next slide. What's our objective? Next slide. So primarily for the well-being of the patient. Next is the well-being of the family. And I'm sure you must have all heard of the new concept of serious health-related suffering. Our aim is to treat all the serious health-related suffering along with the treatment of disease. So there's a diagnosis, but there's also a lot of suffering along with that. So the entity of serious health-related suffering should be taken into account. And if the institution protocol stands in the way, as a palliative care physician, change the protocol, but not the management of the patient. Next slide. Okay, next slide. Yeah, so end-of-life issues. How do we decide on that? So you get the facts right, you get the accuracy, the validity, reliability of facts right. You put all the ethical principles into there, the autonomy, the justice, all the principles are put into it. There are some modifiers when we have all this in there. So there'll be society's modification, the economic, financial modification, legal modification. Consider them all, and then you take the action. Next slide. Yeah. This was the guidelines I talked to you earlier. The Indian Society for Critical Care Medicine has got a conceptual ethical position statement about withdrawing life-sustaining treatment and guidelines for end-of-life and palliative care in Indian Care Unit. You can see this in the when you Google, you can get it. I'll just mention the cardinal points. Next slide. So the physician has a moral and legal obligation to disclose to the capable patient or family with honesty and clarity the prognostic status of the patient with justification when further aggressive support appears non-beneficial. So when we feel that further treatment is not benefiting the patient, it's our responsibility to tell the patient and the family that further treatment is of no benefit. And you start the discussion, initiate the open discussions and the imminence of death. Discuss the benefit and burdens of treatment options. You can treat the patient. There are some trial treatments available, but this is a benefit and these are the burdens. And why should we allow a natural death? We should tell the patient and family about why are we allowing a natural death. Next slide. So, but the physician doesn't have a moral or legal obligation to start a new therapy against his better clinical judgment. As I mentioned earlier, we don't have an obligation to start something just because the patient comes and say, oh, there's a treatment in America that I know, I wanted to do that. And if according to your clinical experience and your clinical expertise, you feel that it's not beneficial to the patient, you're not morally required to start or legally required to start that treatment. And withdrawal or withholding the decision should be implemented after completing a life support limitation form duly signed by the patient's family and treating team. That forms varies to different hospitals. So we write it ourselves. We discuss what we discuss with the patient and the family. We write it down, ask the family to read that, and then sign saying that they know what's happening. They're not consenting to doing it. It's our decision. It's a medical decision. You're not asking the patient to consent, but you're asking them to sign so they understand what's happening. And physician is obliged to provide compassionate, effective palliative care to patient and to attend to the emotional needs of the family. All these are guidelines from the statement. Next slide. This is a recent development that has come. This came in March 2018. I'm sure you must have all read that in the news, where the Supreme Court has said that it's basically about passive euthanasia. We don't use the word passive euthanasia in palliative care, but actually this is a step forward in the right direction, where the privacy, the fundamental right to live and the fundamental right to die is also actually approved by the Supreme Court. So everybody has a die with dignity right also. And this came after the Irina Schonberg case, where, in 2011, the judgment was that passive euthanasia was has a law, then only they can do that. That judgment came. That has been changed by Supreme Court, so that we can actually do it in hospitals now. And they mentioned about advanced directives also in this judgment. Next slide. After that judgment, this first end-of-life protocol has come in Manipal Hospital. This is first of its kind in India. It's called the Blue Maple Booklet, where they've got guidelines that the hospital follows on limitation of life-sustaining treatment and end-of-life for patients with terminal illness without continuing any aggressive medical intervention. So they've just started piloting that in that hospital. Next slide. So Blue Maple basically means that before life ends, understand and evaluate the choice of medical treatment offered, methodized action plan for limitation of life-sustaining treatment and end of life. Next slide. So to summarize, we need to shift the focus from the disease to the person, and death-denying situation to death-accepting situation, critical care to palliative care when life-sustaining treatment is futile. So it's when it reaches a futile stage. Next slide. Always consider balanced compromise based on ethical principles. Communicate early, honestly, and regularly. Clarify, be open to discuss with the others in the field, and consistency within the members of the caring team. We should be consistent in what we're deciding. And if there's issues between the members of the treating team, we need to sit and discuss that. All the team members of the MTT, it's a shared decision. All the members of the MTT must be happy with the decision. Next slide. Okay, as Mahatma Gandhi said, recall the face of the poorest and the most helpless man whom you may have seen, and ask yourself if a step you contemplate is going to be of any use to him before you decide on anything. Okay, thank you.
Thank you, Dr. SUNITHA. So we can have some quick questions. Please come up with your questions.
Does Dr. Geeta want to discuss that patient that she has put as a message to clarify that to everyone?
Dr. Geeta has written. She has a relative like that. Wife knows it is not beneficial, but his relatives insist wife does it. Terrible financial situation, not easy to make patient understand. All decision must be made early. Okay. So this is a patient who I think is getting some treatment which is not beneficial for the patient. And wife is continuing to do that because of the pressure from the relatives, and they also have financial problems. So what should we be doing in this situation? Anybody? So here the treatment seems to be futile. And what does the patient want? Any idea? Dr. Geeta?
I think she's typing.
Please. Okay, Dr. Geeta.
He wants to continue. That is why he has got a tube inserted. He has got a chronic cirrhosis, and it is secondary to pancreatic involvement. He's in severe pain also. So intermittently they get admitted, and then intermittently he gets treatment, and then all other time he just goes and does whatever he wants. So he just likes to be like that. Actually, wives, we are all wives relatives. So we all know this, but we are just continuing. What can she do? Okay, we say, okay, let his wish be there. People support him.
So a patient with advanced cirrhosis, having what problem? Pain or something else?
cirrhosis, and he has got chronic pancreatitis.
Okay.
Chronic pancreatitis.
Okay. What futile treatment is he getting?
No, not actually futile. He had the esophageal varices and all. Intermittently, it gets treated like sclerosing and all. They do, but when the child he becomes very sick and he gets admitted, everything is being done and he again picks up.
Okay.
But he is not on this methodized treatment. No, like he has to be like on this sort of treatment. It is actually a lot of poor compliance from the patient also. They cannot afford this renal transplant and all. Sorry, renal and hepatic transplant and all. So that decision they have anyway made. They cannot afford that much treatment. But it's in a way because he hardly weighs 35 kilos now. 35 kilos, an adult person.
Okay.
He has got this test to live. So
Okay, so this patient with cirrhosis, he has frequent problems and is getting admitted. But whenever he is getting admitted, he is coming up from that problem. And is he having a good quality of life after the interventions?
for him, it is okay. It's actually the quality of life of the wife is very poor.
Okay, so here the autonomy of the patient versus autonomy of the family, and we don't know about the beneficence and the non-maleficence, and also we don't know how far we should go to treat this patient. Like are we going to get admitted him in a hospital when some problems occurs? So okay, personality of wife and patient is different. Okay. So Sunitha, this is a difficult situation. Yeah.
Yeah, I think that's quite that's an interesting case, and I think it's a typical. Probably his ethanol excess also. Alcohol could be the reason.
Yeah.
It is, isn't it? So it's a typical scenario of an alcoholic liver disease patient who comes in with the all these symptoms of all the stages. But the difficult problem here is we don't know how bad the liver is. So it's the gastroenterologist who has to decide. It's have the raise end stage or not, or is it in the? It's not reversible. But when we do the Child's scoring for the cirrhosis of liver, is it Child's A, Child's B, Child's C? So once you reach Child's C, and then it's the worst one, isn't it? So I think the first thing to know is this person, he'll go and drink again, and that's the reason even if he wants to have transplant, they won't do it because they have to be abstaining from, it's like more than 1 year before for liver disease patient to get a transplant. This is a social situation where he is an alcoholic, he drinks, that affects the wife. Once he drinks, he gets antiviruses, he comes in again, and it's going to drain all the, and it's very, very difficult. I don't think even gastroenterologists will still treat him because he might not be in that state of Child C whether it's irreversible. And one of these days, it's going to it's a situation when he'll have a very massive GI bleed and probably might not come out. Fear of what the society might say. Because Dr. Gita has written, many situations relatives might insist on continuing. It should be. I think that's where our job comes in. So basically, not palliative care. I would probably say about the gastrophysicians. They would be able to know, or they will explain to him that in what situation they can stop treatment and they shouldn't be doing anymore. Because if he's going to continue to drink alcohol, this is not going to get any better anyway. So he himself is, causing that to deteriorate further. So it's like threatening him to say that we won't give you any more blood transfusion if you drink alcohol. What else can you tell that patient, isn't it? It's not easy.
Okay. So in ethics, sometimes we will not reach at a conclusion. We can speak for pros and cons, and then it's all depends on what the family and the patient wants. But we can always try to help them to talk to the patient and wife separately, and also asking them to sit together. And if we can facilitate something, it is well and good. So in this, there is another comment. In many situations, the relatives might insist on continuing futile treatment because of fear of what the society might say. Yeah, that's very much true because some patients are brought to us telling we know that there is nothing much can be done, but we have brought him here because of the pressure from the relatives. So in such situations, we sit with them and talk to the caregivers and tell them, okay, if you can bring the relatives, we can talk to them, and if you can also talk to them and tell them that doctor has told like this. The There is no need for doing the futile treatment, which will do more harm to the patient than doing good. So that's how we usually go about that. Okay, Sunitha, do you have any comments on the situation?
Yeah, no. I think probably with the relatives issue, we should be more stern in saying that it doesn't matter what the society says; it's what we want for the best interest of the patient. And we will not be giving any futile treatment just because to please. And it's just a question of maybe talking to them and communicating and making them understand. Because end of the day, our responsibility is for the patient and not to make the relatives or the society happy. So we should be able to talk like that. Yeah.
I think we are running behind time, so we will move to the patient story. Dr. Riyas will be presenting the patient story. I know there will be many questions in this ethics, but we don't have time to discuss it now. So you can send your doubts either as chat or you can send mail to us.
I hope Dr. Geeta will be presenting in behalf of Dr. Riaz.
Yes. Yes. He said he is in some meeting, he said.
Okay, doctor, you can continue.
Okay. Good afternoon. I'll be presenting on behalf of Dr. Riaz. And he being an endocrinologist, he has taken a patient from his clinic. But I think these are sort of patients who come for all of us. So we currently have got another patient of like this. So this is a adolescent boy. He was it's around 17 years. And the diagnosis is diabetes, that is type 1 diabetes with chronic calcific pancreatitis. And the person has got, he's got, due to various problems, he has in a clinical stage of depression also. So initially, the child was okay till around 11 years, and he presented to our casualty with an acute onset of an abdominal pain. And he had pancreatitis at that time, and the diabetes which occurred was following that. And the last symptom of depression was because of this chronic diseases which he has been having for all these years. And the first, actually, it is for a pediatrician, that is the most important one. There is a child presented, he was a healthy boy, he was doing everything in school, and suddenly with an acute abdominal pain, he presented. And you all know, with pancreatitis, it's one of the worst diseases which we can have. Severe excruciating pain. The child was on orally and was on parenteral fluids, then parenteral drugs, and he was on a long period. And he had multiple problems. That is, initially he had intensive care for a long time. Then he developed some effusions in the peritoneal cavity. He developed something like pseudotumor, and then he developed the pancreatic fistula. So multiple surgeries were also being done for an initial few years. And then after say around 4 or 5 years, he was on regular follow-up. He had a very poor quality of life, because he could not have anything which the normal children take, like chocolates, and the children take many of the things. And he was on a very restricted diet, especially with carbohydrates and all. And then he developed this diabetes, and we all know it is a complication of pancreatitis. And then he was started on insulin. And then actually, a child with diabetes type 1, itself has got a lot of problems, and then on top of his restricted diet, he had difficulty to go to school and all, and then he had this diabetes also. So both things were being done, and then the parents actually say that he has now lost interest in his studies, and then on further questioning me now that he takes insulin on his own, but over few years he doesn't stick to the schedule. He doesn't rotate the site of injections. So again, he developed some complications of this injection, like this lipo dystrophy and all at the site. And then, the parents say that, he has got a lot of problems regarding schooling, a number of school days lost and all. But parents, somehow, parents bring the child, but they actually do lots for this child. And then, the child doesn't do well in studies, and he has got, it's always in a sort of pensive mode, sad, like that. That is what the parents say. That means, and you can see that he has got that growth and all is so much small. 17-year-old child, he has not gone into puberty when compared with his peers. He has got a weight and height which is very less. That is when compared with his peers, and that is the thing. And he has got little hepatomegaly also. We know hepatomegaly occurs with the long-standing type 1 diabetes, and so that is a problem. He is a very short child. There is a really wasted child due to both exocrine and endocrine pancreas problems. And when compared with his peers, he is not gone into the puberty. That means he is still like a very small child, and he has got a lot of metabolic problems also. And it is basically his diabetic status is not well controlled. That is thing. And he actually there are a lot of things a diabetic child and a child with a chronic disease has to be on for control. So because he being a puberty, he has got a lot of problems regarding the pubertal issues also, and so he is not actually complying with most of the treatment. We actually offer treatment based on a clinic basis. So that is, he has to do that, but the parents mother says that he is not actually following. That means earlier he was very compliant with the treatment, but now he is not. So that is the situation. And as most of we are from a government institution, and we have got mostly children who have got problems, chronic problems, especially from the lower socioeconomic status. And they have got a lot of issues regarding this. Mother is a single mother and she is working somewhere. So whenever she wants to bring the child, she will have to take leave from that place. And mother is very good. That is why all of our mothers who come to these clinics and all are exceptionally determined. And so that is why she is finding a problem now. She is actually doing so much to bring up this child. But this child has got some problems, and this is the current treatment on which this child is on. That is supplementation of exocrine pancreas, and then he is on protein pump inhibitors for this, and for his behavioral problems he is on fluoxetine, and he is on a insulin also, daily, long acting and regular. That is for his control. And he is actually really good because the mother maintains the diary exceptionally good. But because whenever they come, we say this glucose, this HbA1c is not now getting control. So that, they know the problem, and now the mother has come forth with why it is not being done. That is why that loss of control has occurred recently. And now she feels that probably that his behavioral problems may worsen, because in their locality they say that it's not a good, actually being in an urban slum and all, it's not good for any person, let's more so with chronic disabilities, or chronic problems. So the main concerns for this child, according to the mother and for the treating doctor, is he has got pain, intermittent pain, sometimes get worsens, needs admission, and then he has got recently this depressive problem, which he says by futility of life. So that is the recent problem which they have developed. And the family has got financial problems all through, and more so when being an adolescent, the mother says that most of her relatives or somebody, their children are studying or earning. This child, now she is actually finding it difficult to have special diet and all for him when compared with the other family members like that. So these are her problems. So this is a child with 16, it's an adolescent, 16 year completed 17-year-old with chronic calcific pancreatitis with the type 1 diabetes after that, and then he has got the problem is he has got intermittent episodes of pain, episodes he has got depression, and some episodes of suicidal ideations and the socioeconomic issues. That's a situation.
So thank you, madam. So this is a 16-year-old boy with chronic pancreatitis with diabetes mellitus who is on step 2 opioids, complaining of pain, and has suicidal ideations on fluoxetine. And psychosocial history is also seems to be he is facing many problems. Yeah. So anybody want to suggest any solution for this?
GCRIT?
Okay, ma'am. Ma'am, first I want to talk about this suicidal ideation. First, we have to change this antidepressant drug because fluoxetine can cause paradoxical suicide. So we can also give sertraline or escitalopram, which has also anxiolytic property and less interaction with other medication.
Okay.
And we cannot give fluoxetine at HS dose because it can cause sleep disturbance also. It's self-activating molecule.
Okay. So you change fluoxetine and want to start on escitalopram or sertraline.
Okay.
GCRA?
Sertraline or escitalopram.
Okay. So what is the advantage of escitalopram or sertraline? So can you tell us what is the advantage of sertraline or escitalopram in this situation?
Yes, we can start sertraline from 25 milligram. We can also increase according to response. And if we want to start escitalopram, we can start with 10 mg, 10 milligram.
Yeah, we got it. We just want to know that he is already on SSRI, fluoxetine. So why do you want to change from fluoxetine to sertraline or escitalopram?
Because, yes, as patient has already suicidal ideation and fluoxetine is activating molecule, the black box warning of fluoxetine is paradoxical suicide. It can increase psychomotor activity.
Okay.
Hello.
Okay, yeah, we have that. Yeah, thank you.
May I pitch in the
Jiten, yeah.
good afternoon, everyone. Regarding the my comments on the managing the depression for the patient, it may not just be changing the antidepressants. There are few changes that I would require. I think my video is hello.
Yeah, you are not very much audible, so we have just switched off your video.
Okay. Regarding his antidepressant treatment, there are certain changes that I would also like to see.
Yeah.
The first thing is his suicidal ideation is primarily because of the psychosocial problem, I would say. So changing an antidepressant is sorry, just managing that by antidepressant may not be the option. Probably an intense counseling is what he requires. If the support of a psychotherapist, if it can be robbed in, that is one thing. That is one. Second, even if we are thinking of changing the antidepressant, few things. One is right now the fluoxetine is given as an HS dosage. If we are thinking of continuing fluoxetine, then change that from HS to morning dosage. Second, antidepressant, most of the SSRIs has got suicide as a risk factor, but what I would say, it's not very common. It's not very common for a person to have that much of activating effect and he'll go and commit suicide. I don't think that much of evidence for that is not that great. But if we are thinking, escitalopram will be a good option compared to fluoxetine and sertraline, because both these have got interaction with other drugs. Escitalopram has got lesser interaction with other drugs. And sir, one more thing is that whenever we are dealing with pain and depression, sir, rather than SSRI, there are some evidence that SNRI, like venlafaxine or duloxetine, may work better. These are my inputs.
Okay, thank you, Dr. Jin, for your inputs. So, shall we discuss what should be done for his persisting pain?
Yes.
He's already on tramadol, 50 milligram BD.
That
Yes, Dr. Geeta.
actually, regarding this patient, I do not know the day-to-day activities.
Yeah.
He only told me regarding this patient. We have got patients like that, but regarding this patient, the other drugs, he's currently only on these, no other drugs.
Okay. Anybody want to comment on pain treatment for this patient with chronic calcific pancreatitis? Sunitha, have you seen patients like chronic calcific pancreatitis who's having severe pain, and because of poor pain relief, they have many problems, even that can cause depression?
Yeah, but not such a young child. Adult patients I've seen, and they come with recurrent episodes of pain. I think when we admit them, we have to give them morphine. But some patients are on oral morphine long term. But I don't advise that, because obviously it's a non-cancer condition. I wouldn't give strong opioids long term. But unfortunately, the pain is very bad. I think neuropathic agents probably should be started earlier on, because there could be nerve involvement, and because we've gone for just like the other doctor said about the changing duloxetine or venlafaxine. If that is effective for depression, maybe that could be done, or we add in anticonvulsants and see whether the pediatric dosage and see whether that works. And I think he needs lots of support, peer group support, counseling with that age. Whether you can actually find other patients, if you've got any support groups available, that other patients of his age, if that's possible to find them, because he's got a long journey in front of him with this pain, and chronic pain is going to be a major issue. If at all any opioid is indicated for chronic non-cancer pain, I would usually go for buprenorphine only, because buprenorphine is as patches, and that is proven to be better, has got not long-term side effects of opioid. The other problem is opioids do have long-term side effects, which we haven't studied in our patients because ours is a cancer group. So normally for non-cancer pain, I wouldn't give them long-term opioids, only for short-term.
Okay, thank you. We have some patients who has chronic non-cancer pain, and mostly patients are having POVDs, chronic calcific pancreatitis, and we have only morphine and methadone as a step 3 opioid. So many patients are referred to us after trying with tramadol. We usually start them on step 3 opioids like usually on morphine, and monitor the patient, and when the acute event is over, if possible, we try to withdraw the morphine and put it on step 2 opioid, and regularly monitor the patient.
Can any of the interventions work for them? I think the celiac plexus blockade, can that work for these patients? I'm sure I've referred one patient for that.
Yeah, there are some patients who can get some help with interventions like celiac plexus block, but that we can't make sure that that will help 100%. Sometimes the requirement of analgesia will come down, and the effect may also, it may not last long. So GCRI, you have a comment?
Yes, we were talking about the same. Celiac plexus block may work in this patient, but his patient is diabetic. We may require very aseptic, antiseptic precautions proper, and patient may develop some complications also. But celiac plexus block is last resort. It may work. It works.
Okay, thank you. What family support can we offer for this patient? Any idea? So, single parent with with a child who has a chronic problem. So, what should be the support we offering to the mother or for the patient? Anybody? Sunitha?
I'm not sure what is available. I think Dr. Geeta has sent saying that local self-government gives a monthly income but low. What about, teaching her some vocational activities so she can do some work and earn income if income is a major issue? She's only studied till 12th standard, isn't it? So I don't know what job she can do, but support her to find a job. Yeah, something like that. Can't think of anything else.
Yeah, I think that can be done with the help of NGOs or with the help of somebody. So maybe we have to find out what does the mother knows, usually tailoring or something which they will be very interested in. So if we can buy a tailoring machine and help her, that will be good for the family. And even we can think of the patient himself involving in some vocational rehabilitation, which will give him more, which will make him more happy, and he will feel that he is involved in something, and he will feel that he is worthful to the family. So that will also help him in treating depression, I think. Okay. So anybody has any more comments on this?
I have, sir, Dr. Jitin here.
Dr. Jitin, yes, please.
Sir, this is not a comment. This I am myself doubting whether there is a treatment option in such scenario or not. Sir, the only proven psychiatric treatment which is effective in intense suicidal ideation is ECT only, electroconvulsive therapy. So I'm not sure, sir, in palliative care, the application of ECT I have not done in any of such cases. I don't know about other centers. But I compared to the antidepressant medication or any other medication in psychiatry, the only treatment which has got proven efficacy is ECT. So any input from you, sir?
Sorry, I don't have any experience on this. Yesterday we were discussing about ECT because we have psychiatry pages posted with us. So I don't know actually. I am not a person to comment on that. But there are two pages here who can comment on this. Okay, GCRI.
Yes, we can give him ECT for active suicidal ideation, but we required pre of like anesthetic fitness before that.
So before that, so actually, this really mention of suicidal ideation. Has anybody taken a proper history? Has he done that before? Has he attempted that? What his exact thoughts? How many times he has done it, and all those things we need to assess, right, before we decide on that.
Yes, ma'am. Definitely, detailed assessment is required. But I was actually thinking, not specifically for this patient, but a palliative care patient having intense suicidal ideas, probably might have tried earlier. I mean, I was thinking loud whether ECT is an option for this. For every patient who is undergoing ECT for an indication of suicidal ideation, all detailed psychiatric evaluation needs to be done, including the level of suicide ideation and the lethality of the ideation that he has got.
Okay. Sunitha, any more comments?
Your opinion about informing the patient and bystanders not informing the patient, patient not knowing of the diagnosis. Do you want to put anything about that?
Okay, so this is a very common situation which we usually face. So, in the ethical principles, autonomy is considered as the overriding principle, and this is a very difficult situation that we are facing because we have to respect the autonomy of the patient, which we say as the overriding principle. But at the same time, we have to also respect the autonomy of the family because as Sunitha says, in UK or US, the patient himself or herself are coming for the treatment. They take decision by themselves and do all the things by themselves. But when we come to our culture, the family will be bringing the patient to us. Family is accompanying the patient throughout the illness, and they are taking a decision on behalf of the patient. So the problem is also have to respect the family's wish. So what we usually do is we work with the family members and we will tell them the need of communicating the bad news to the patient. So that's how usually we go about that. And in many situations, we will be able to do or communicate the bad news with the patient. And in some situations, we have to continue the dialogue with the family for long time, and then only they will agree. So in that situations, otherwise, what happens as Dr. Sunitha told, they will take the patient somewhere else. That's what usually happens, and they will, and without their wish, if you communicate the bad news, they will also get angry, and that's a real situation that has happened. So I think we will close this session now. So for this patient, we discussed about um, uh, giving counseling, supportive psychotherapy, and fluoxetine given in the morning, and citalopram can also be given, but considering the pain and all other symptoms, venlafaxine might be better. And we also mentioned about ECT might be an option. Then for pain management, maybe for the acute event, we can start him on step 3 opioids, and once the acute event is over, step down, and maybe continue with tramadol, and also add neuropathic pain agents like anti-epileptic medications or tricyclic antidepressants or SNRIs. And to help the family, we can have frequent interactions with the family, and also try for vocational rehabilitation for the mother and for the child also. So thank you, Dr. Sunitha, for joining us and having a good session for today.
Thank you.
And thank you, Dr. Geeta, for presenting the patient story on behalf of Dr. Ayas. And thank you all for interactive session. We'll see you on next
Thursday with a topic on difficult pain. So I have provided the feedback link. Please do the feedback. Thank you, Dr. Sunitha, and thank you, Dr.